Hello and welcome to this Make a Medic presentation on dementia. So to start off, dementia is a syndrome, meaning that it's a collection of symptoms. And one of these symptoms is typically significant memory impairment. However, this may not actually be the first symptom that presents, and it's irreversible. This separates dementia from similar psychiatric conditions. For dementia to be diagnosed, we expect to see symptoms in at least two cognitive domains. One of these is memory, but others could include language, such as word-finding difficulties, behaviour, such as disinhibition, visuospatial, such as difficulty sequencing activities, and executive functions such as decision-making. The memory impairment to be diagnosed must be impacting on usual activities such as work, and as mentioned, the dementia is not reversible, otherwise we may consider other conditions. There are various subtypes of dementia. Here are four of the key ones to be aware of: Alzheimer's, vascular, Lewy body or Parkinson's with dementia, and frontotemporal dementia. There are also rarer types, or some patients could be diagnosed with a mixed type such as Alzheimer's and vascular. First of all, Alzheimer's. So memory problems are typically one of the first signs of cognitive impairment related to Alzheimer's, but this can still vary between individuals. For many, decline in the non-memory aspects of cognition, such as word finding, visuospatial issues, and impaired reasoning or judgment, could also signal the very early stages of disease. In terms of the pathology, we see abnormal clumps known as amyloid plaques and tangled bundles of fibres known as neurofibrillary or tau tangles building up in different parts of the brain. We also see a loss of connections between neurons. The parts of the brain being affected will relate to the symptoms that the person experiences. Typically, it's the hippocampus and the entorhinal complex that seem to be some of the first areas affected. Moving to vascular, this is where there's a disruption of blood flow to the brain, such as in a stroke, that leads to irreversible damage. The symptoms will often progress in a stepwise manner depending on the insult to the brain, and the risk factors are largely similar to stroke, for example, raised cholesterol or high blood pressure. Next, Lewy body dementia. So this is the form of dementia that is often linked with Parkinson's disease, and the diagnosis will depend on whether it's the memory or movement component that occurs first. Many patients will eventually have symptoms of both. In this condition, Lewy bodies deposit in the brain that disrupts neural function and seems to also lead to some neuronal loss. And in addition to the memory loss seen in other forms of dementia, there are some additional symptoms we tend to see in Lewy body, such as hallucinations, low mood, and difficulties with sleep, such as daytime drowsiness or REM sleep disorder. And it can also be possible to see the symptoms of Parkinson's disease, such as a resting tremor, cogwheel rigidity, or limited facial expressions. And finally, frontotemporal. This often has an earlier onset at around 45 to 60 years, and the cause is still largely unknown, but thought to be genetic. The presentation will again depend where in the brain is being affected, but we often see personality changes and disinhibition due to the effect on the frontal lobe. There are some key differentials to be aware of, such as mild cognitive impairment, which is worsening memory but not to the extent of dementia, depression or bereavement, which particularly in the elderly can lead to memory loss as well, and delirium, which is more of an acute presentation, often linked with infections or organic illnesses, and that can be more fluctuating over time. In terms of assessment, we can break it down into history, examination, and investigations, similar to other areas of medicine. So if we start by thinking about the history, the timescale of onset is really important. In dementia, we expect there to be an insidious onset of slow progression of months to years, consistent with a degenerative process. If the changes are more abrupt or stepwise, that could indicate a vascular cause, but a rapid onset would be more consistent with an acute confusional state or delirium. As mentioned previously, the symptoms need to be impacting on the activities of daily life, things like eating, bathing, continence, personal finances, and taking medications. And it's also important to ask about safety in the home and outside, social functioning, and whether the person is currently driving. You'll need to take a medication history. There are some common prescribed medications associated with increased anticholinergic burden and therefore cognitive impairment, which would include things like benzodiazepines. You'll want to ask about a family history of dementia and alcohol or drug use. In terms of examination, we're looking for focal neurological signs that could indicate an intracranial pathology. Look for coordination and gait abnormalities, sensory findings, and motor symptoms. That's also important if you're screening for signs of Parkinson's disease linked with Lewy body dementia, things like tremor, rigidity, and bradykinesia. You may look for visual or auditory problems. Cardiovascular signs are important if we're considering vascular dementia, things like hypertension, arrhythmias, or peripheral vascular disease. And you also want to be screening for other causes, things like head trauma or delirium and infection. And then finally, investigations. Blood tests are important because they can often screen for reversible causes of cognitive impairment. So those ones listed on the screen are some of the key tests we would perform. You may also choose to perform a chest X-ray or an MSU if you're thinking about screening for infection. And we may perform brain imaging, such as a CT head. And when we're assessing cognition, that's when we need to use validated cognitive assessment tools. Thank you.